It's lovely, all these early birds, because we're only at 12:30 already, and we've got lots of colleagues coming in, which is great. Hi, Wax.
Hi, everybody. You okay? Yeah. Sorry, a bit late.
No, you're not. You're bang on time.
Yeah. How is everybody? Everybody okay? Sun's out today. It's nice for a Friday. Bit chilly.
We were just saying, I don't think anyone's daring to say it, but they're all feeling like it's okay and it's not too crazy. But no one wants to confess it in case it all goes.
Because I think we've all got used to you know, things that might just come around the corner kind of situation, and then sort of be alive and alert to that. But
yeah,
if you are in that restful space, that's let's hope that stretches out.
Yeah.
as long as we can keep it stretched out.
Got 26 with us now, Nadeem, so I don't know if you want to hang on us a minute or so.
Yeah, we'll start at 35 past.
Perfect. That's perfect. Hi, Subir.
Hi, you okay?
Yeah, we're good. I think we're all enjoying the sunshine.
Definitely.
Although we are inside, obviously.
Yes. We have a false sense of security that everything is over. Oh. Just as everyone's coming in, perhaps, I mean, I know Nadeem will, but just to remind you, we will record the session and we'll share the slides and notes out to everyone. So hopefully you don't need to take too many notes, just listen intently and engage. And it will be also shared with Metropolitan Police.
That would breach IG rules. To be, so I can't do that.
Maggie, can you get the agenda up, please? I think we'll just start now, Karen. Hi, everyone. Yeah. Welcome to the February NHC webinar. As you can see, it's especially packed today, the agenda. Just a reminder, it's a recorded session, and any questions, if you can put them in the chat bar, please, or raise your hand and we'll get round to you. And if you can please mute if you're not speaking due to the interference it causes. And just for the presenters, if you could just be mindful of the timings, because we want to make sure we've got enough time for questions along with the presentation. So I'll hand over to Nazmul. Hi, Nazmul. I think today you're here as the dermatology lead for T&W, is that correct? Tower Hamlet from Forest and Newham.
Correct. Thank you. Can you hear me?
Yes, we can, Nazmul. So I'll hand over to you. You can talk to us a bit about your dermatology project.
Thanks. Next slide, please. So I'm Nazmul. I'm a GP, and I'm the GP clinical lead for the 3 CCGs, and I'm working on the dermatology transformation across the CCGs. Some lots of interesting and exciting stuff coming along around single point of access for dermatology and other stuff, including training and education. But I want to focus today on the dermatology 2-week pilot. We've got a huge number of practices who have opted into the pilot. Now we've got about 110 practices, so we can't call it a pilot anymore. It's kind of a project. Most practices have opted in. The aim of the pilot is really it's running over 2 months, March and April, and the ask is to see whether consultants can safely triage pigmented skin lesions that we send through 2-week wait with the additional dermatoscopes. So for those who don't know what a dermatoscope is, it's basically a digital kind of camera that you attach onto your smartphone, and it takes the images of the pigmented lesions, and then you can send that image with the 2-week wait referral form to the consultants. The consultants can then decide whether that patient needs to be booked directly into surgery rather than having to wait unnecessarily for an appointment, or whether that patient could be stepped down and that clinic be freed up for lesions which are more kind of serious. Next slide, please. So we've got about 110 practices that have been signed up across T&W. What we're asking is colleagues to attach an image with the scope with the 2-week referral form. If you could go back to the third slide, please. Thanks. The third slide. Thank you. So the scopes are worth around £500, including VAT. I have some scopes left, and I'm offering a second scope for larger practices with a list size of more than 10,000. We've delivered a training session around how to use the scope and how to attach it onto your smartphones. All we're asking is, if you've got a patient who needs to be referred on a 2-week wait dermatology clinic, attach the image with the dermatoscope and send it to the 2-week wait through the normal route. And for that, you'll get between March and April additional £10 for every referral that you make. If you do make referrals, please note the EMIS number of that patient, so you'll get remuneration for your time and effort for that. And also there is some additional funding limited to any GPs who want to sit in on a 2-week wait clinic. So these are the referrals that we make into secondary care. If you want to sit in with the consultant and observe what happens in the clinics, how to use the devices themselves, or what happens in surgery, there's a remuneration of £200 to free up GP time and go to the Royal London or Barts and sit in with a consultant and improve your skills and knowledge around that. If you could go to slide number 2, please. If all clinicians could kindly, slide number 2, scan this QR code, save it on your phone. There is a questionnaire that I kindly ask you to complete. It's very short, and this is really to do a needs assessment to see what sort of training around 2-week wait lesions colleagues need. It's quite interactive, and there's lots of really interesting photos on it, and there's a bar there to kind of rate your confidence level around diagnosing or labeling certain lesions. So if you could scan that and save it on your phone and do it when it is convenient for you. Thank you. Last slide, please. So like I said, most practices have signed up and they've collected the scopes. If you are a practice who hasn't received one and you would like to receive a scope, please email me ASAP. Training is going to be delivered on the 24th. You should have received an email through the commissioners around the invitations and details on how to kind of enter that training session. Those practices who have signed up and haven't received the scope, it was sent through DPD tracking, so we can still locate that device, but I haven't received any emails of people saying they haven't received the scopes, which was sent around December time. That's it from me, and I'm happy to take any questions from colleagues or any queries.
Thanks, Nazmul. Yeah, it sounds like good CPD, and also you get a dermatoscope in the practice, so it seems like a win-win. Sophie's got a question. Sophie, I don't know if you want to say out your question. It's quite long.
Plus also you can get a reimbursement of £200. I've knocked on many doors and finally people have given me some money. Many doors I've knocked on, but the CCG have been understanding and generous, and it shows that with persistence you can get the money.
Okay, Sophie's asking about using the Pando app because they're not identified as Newham GPs. So is this a TNW project, Nazmul, or is it a NIL project?
It's a TNW project. So we purchased around, I think, 500 licenses for colleagues to upload Pando. So Pando is an app you can use to upload the image on your phone, which doesn't save it onto your hard phone itself, because there's a potential data breach. If you can use your phone, but make sure you switch off the Wi-Fi, because it then saves it onto cloud. Pando bypasses that, so you can save the image onto Pando, and then you need to email the images from Pando onto your NHS email and then upload it. But we are working on a specific software to see if we can bypass that and make things more streamlined.
Yeah, so Sophie's question is saying they've got GPs who can't use the Pando app as they're not registered as Newham GPs or recognised.
Okay,
it might be something.
Sure, those who have had problems downloading the app, then email me. I'll bypass that and contact Pando and get you the permission to download that app. If you need to use something now, then again you can use your phones, but switch off the Wi-Fi cloud and just give us a second. You can email it to yourself.
Sure, and Hiran's having some problems attaching a lens to the phone.
Yes,
so again,
there will be problems. There's a video there, and if you're having problems, you can come and see me, or I'm happy to give you a tutorial via Teams. Most smartphones should be able to attach the devices. There are some, minor issues, but they're really amazing things. You can zoom in the lesion, zoom out, and do fancy things. There's a polarized version.
And how many dermatoscopes are you giving out? Have you given out at the moment, or have you got left to give out?
I've got left. So bigger practices list size more than 10,000. I'm going to give an extra one, and if you're a practice which is a high referrer, then I can give you a third one. Like I said, the device is worth about £500, and that's for you to keep, not to return.
Great, sounds all sounds good. Any questions, Karen, on the chat bar?
No, you've got them covered off already.
Okay.
So
I mean, you've got most of
the
the practices signed up. You don't really need any more kind of exposure, do you?
Well, the device is for you to keep later on, because things are now becoming digital. So you'll need a scope, and it's £500 that NHS England are giving it to you. If a practice doesn't want it, that's not a problem. I'll just allocate it to another practice who is in need of one. So there's no kind of mandate for you to come and collect it. It's optional. There's remuneration for that, and I think it's a fantastic incentive. Thanks, guys.
So you got your email there on the presentation. Just Nazmul, I think it's nazmul.hussain1@nhs.net. So just email Nazmul if you want to be part of it, if you're part of that 6%. But thank you, Nazmul. It was really good.
Thanks for the time.
Sounds like a great project. Thank you. Should we go on? Hi, Sabir.
Hi, Sai.
Hi, Sabir.
Can I just start then? Yeah, now we're okay.
Yeah, sure. If you just want to introduce.
So I just wanted to bring everybody's attention to the new things we have discovered when we are assisting one of the practice on CQC query. So there is a CLOE, which is called Key Line of Inquiry. Say, what is the practice policy on managing control drug? And we are very comfortable to say we don't have any control drug, so we don't do anything. So that's the easy answer. But the next question is not easy. Next question is that, do you know who is your control drug accountable officer? Then you will be completely gone, because most of the people probably doesn't know who is, even that post exists, we don't even know it. But I have a pleasure to meet Sarah Dennison, I think a few weeks ago, when we discovered that she is our control drug accountable officer. So the floor are hard to tell what exactly she do, how we can contact her, and when the CQC come, what answer we should give it to her. All over to Sarah Dennison. Thank you, Sarah, for coming.
Subir, thank you for the introduction. So I'm really conscious that I'm going to give you a very whistle-stop tour of the role and function of our team today. So what I'm going to do for about 3 or 4 slides is just talk you through kind of what my team cover, what we do, why we do it, and then Vijay Saravanan, who is also in my team, is just going to share a couple of the screenshots of the controlled drug reporting tool that I'm going to mention when I go through my slides. So next slide, please. So I don't know if you all could cast your minds back to the time of the Shipman inquiry when it came to light that Harold Shipman had actually killed huge numbers of patients using controlled drugs that he diverted. And this led really to a whole inquiry, and this was followed by a government command report. And as part of all of that, it was identified that lots of people knew little bits about Shipman and had a few niggles and concerns, but they didn't have anywhere to report those concerns into. And as a consequence, out of that came the Controlled Drug Supervision and Management of Use regulations, which at that time were the 2006 regulations, subsequently superseded by the 2013 regulations. And in those regulations, what it sets out is that controlled drug designated bodies, so that's all of your hospitals and hospices and so on and so forth, would need their own controlled drug accountable officer with oversight of all of the controlled drug arrangements within that particular organisation. And in addition, and going back to 2006 when it was PCTs, every PCT would have a controlled drug accountable officer who would then conduct a local intelligence network across all of the services within their patch and would have oversight across that area. Now then in 2013, the NHS England Commissioning Board, which we now know as NHS England and has since amalgamated to become NHS England and Improvement, each of those individual regions of NHS England and Improvement will have a regional controlled drug accountable officer. So I'm the controlled drug accountable officer for the London region, and under my jurisdiction really for oversight of all controlled drug arrangements and governance for London will fall under that remit. So if I can have the next slide, please, I can just show you the range of services that I'm including in this oversight. So as I've said here, the NHS England Improvement CDAO role is to have oversight of controlled drug governance arrangements across the health and care services across our regions. And these will include all of the NHS and independent hospitals, but they separately will have their own accountable officer as part of being a controlled drug designated body. Ambulance services, NHS Trust ambulance services will have their own controlled drug accountable officer. Private services, again, it will be the regional CDAO. Equally, within the region, we will have independent clinics, hospices, GP practices, community pharmacies, health and justice services, dentists, and also all the links, as you might imagine, to the systems. So the CCGs, the integrated care systems when they come on board, the primary care networks and so on. So the bit you're going to be most interested in is how does my role impact on GP practices. So when it comes to GP practices, you won't have your own controlled drug accountable officer, and there won't be a controlled drug accountable officer at CCG level. So it is the regional controlled drug accountable officer that is your main contact for any incidents or concerns that you might have around controlled drugs. But equally, you may well also have reporting mechanisms into your own CCG. So if I can have my next slide, please, I can just talk about all of the functions of my team, what we do and how we do it. So the Controlled Drug Accountable Officer team for London has 6 of us within it. So I'm the CDAO, and then I have some pharmacist professionals also working with me, and also a project manager and a business officer as well, and we're a team of 6. So what are our main functions? Well, all incident and concern reporting around controlled drugs across the London region will come into our team. And if you are a GP practice and you have a controlled drug concern that you need to report into us, you would need to do it through our controlled drug reporting tool. As I said, we'll share some screenshots in a minute. Now, the kind of thing you might be thinking is, well, we don't keep controlled drugs, so why would we have an incident or a concern? Now, it could be that you have a concern, for example, that you want to report into us about an opioid-seeking patient, for example. So you might have a patient who you have a suspicion is turning up at multiple practices, maybe with quite a complicated story about why they've lost their prescription, why they need a supply before they're due their next supply, why they you have concerns that they seem to always come in with quite a complex story about why they need more next time or a higher dose or something. So you might want to report that into us. Unfortunately, there is a little bit of a limit to what we might do, but it might help us to actually track that that patient is accessing multiple services. We'll be able to pull out a trend, and we might be able to have a conversation with you about some next steps to actually provide appropriate support for that patient, and also just to build a bit of a picture of where that patient might be going. And unfortunately, there are quite a lot of opioid-seeking patients across London. They tend to present sometimes in the same sort of area of London, but they might go across different areas of London. They may well go to other regions as well. They may turn up also in secondary care services. You might also want to report into us if you have a concern that a colleague is prescribing for themselves. You might have a concern that a colleague is you're concerned might be diverting controlled drugs, either for their own use or being coerced. And we have had incidents where there was quite a big one actually, not in our region, but we became aware of in a different region, where a practice manager was diverting controlled drugs. Other things that you might want to report into us is where you might have a concern about a prescribing error that's been made. And again, we've had incidents where, for example, particularly in paediatrics, there might be the wrong strength of a controlled drug selected, resulting in an overdose. And this is particularly something that we've noted with sort of specials, paediatric special liquids not being on the appropriate GP prescribing system. Therefore, the GP is not aware of the fact that that patient is actually needing a special, and that's resulted in maybe an adult formulation being prescribed and then subsequently dispensed. The next thing that you can see on my list is occurrence reports, and these are reports that are fed into us by our trusts and hospices, and these are much more a quarterly summary of all of the incidents within their particular organisation. So for the purposes of a GP practice, you don't need to worry about the occurrence reports. Another thing that my service also, my team will also do is authorise destructions. So where we have controlled drug obsolete or expired different preparations, you can actually apply to us and we will temporarily authorise a witness within your organisation to witness the destruction of those controlled drugs. Another area in which we're involved is in the authorisation of CD pins. If you're a GP that wishes to prescribe privately, you do actually need a prescriber identification number from us if you're going to prescribe Schedule 2 or Schedule 3 controlled drugs privately, or if you're going to requisition them. And a CD pin then enables you to obtain the FP10 PCD, which are the pink private prescription pads on which you need to prescribe controlled drugs, as I said, in Schedule 2 or 3 privately. What we also do is we do some monitoring work, and at the moment we've been looking at a number of controlled drugs being prescribed both privately and in primary care, and then looking to see if we've identified any concerns. What we've done is we've looked at pethidine prescribing, for example, in private and primary care. We're in the process of actually distilling down how many pethidine prescriptions we've received, we're aware of, if you like, in primary care, and then probably through our CCG meds management leads, we'll actually have conversations about anything, and how we might then follow up with individual practices, or whether in fact they might do it. So we do actually undertake some monitoring work, and we do that across, as I said, both our private prescribers and our primary care prescribers. And we might pick out different themes depending on what we might be particularly wanting to follow up. We also look at requisitions and to see if there's anything unusual being requisitioned. Another area we've looked at in terms of monitoring is where we've seen, for example, injectable controlled drugs being prescribed, because again, you wouldn't expect to see great numbers, particularly say things like ketamine being prescribed in primary care. So those are the sorts of things that we might be monitoring at the moment. As I said as well, we do hold local intelligence network meetings, or we will run meetings like this where we want to try and engage with small groups of healthcare professionals. And this is actually our first opportunity really to engage with GPs. We're very grateful to you for inviting us, and it's something that we might consider rolling out to other GP areas if we get feedback from yourselves that this has been useful. And we've also developed a controlled drug newsletter. Please, if you haven't received it and you're interested, let us know and we can arrange for a copy to be sent out to you via email. We've sent out our first newsletter in the winter of 2021, and there'll be another one in sort of early summer, and really it just has useful information about what we're doing, any particular errors we're coming across that might be useful to highlight to yourselves, and any particular information or contact details and so on and so forth for our team, and associated relevant guidance that might be coming out, or any changes in legislation. Obviously, also we like to provide some support, and so we have the generic mailbox, which you can see on the screen. So if you have a generic kind of query or support request, then we'll be happy to try and help. And as I said, we have generalised oversight and reporting, so we try to distill down any trends or themes or sort of wider concerns that anyone might have as part of our function. Vijay, can I hand over to you just to share the CD reporting screenshots so that the GPs on the call can actually have some familiarity with it if they do then register. Thank you.
Definitely. Thank you, Sarah. Hi, everyone. So yeah, I just want, as Sarah said, I just wanted to share over the next couple of slides what the CD reporting tool looked like. And so that was the link that Sarah referenced earlier on. And when you click on that, mostly with most of your organizations, I would have thought you would need to register. So you would come on to, so you'd need to register. The registration page is very, very simple and is very quick as well. So I know how busy everyone is, especially within your practices. Next slide, please. So after registration, you'd be taken on to a couple of pages where there are various forms, which Sarah alluded to, and the two main ones that you may use. So you can see destructions there. So if any of you do hold Schedule 2 controlled drugs and they become expired or obsolete, in order to obtain an authorised witness, that's where the request would come to us. More than likely, though, you would probably be using this form for the incidents and concerns and reporting those to us. So next slide, please. So these are just some screenshots of the incident concerns reporting form. So again, it's very progressive, very easy to use, and it's just input information around what happened, who was involved, which controlled drugs were involved. And then that comes directly to the CDIO team, to us, and it's reviewed and any follow-ups are done. And Sarah shared some of the things that you could report, and it would be all things controlled drug related, really. So any incidents, prescribing issues, over-prescribing issues that have come to light. It may well be a controlled drug incident that you've learnt about involving another organisation, a community pharmacy. Please don't assume that it's being reported in by someone else. If you have an incident or a concern that you're aware of, report it to us. It could be a non-medical prescriber issue. It could involve any healthcare professional, or it could involve another individual as well. And in terms of concerns, it may involve individuals where there's some kind of concern relating to their prescribing practice, or that they may be diverting. So everything that Sarah said earlier on. And whether something is under investigation or whether at the moment it is just a concern, absolutely best practice would be to report it into us as early as possible with as much information as you have, because no doubt we'll be able to provide guidance. We may have precedents of something happening already which has similar streams, and actually that's our job in terms of oversight of incidents and concerns. We can share best practice. We analyze and collate key trends, themes and learnings, so we'll actually be able to support you and guide you through that. I mean, if we draw back to Sarah's very first slide around the shipment inquiry, definitely one of the outcomes from that was early intervention was unfortunately missed because awareness just was not raised. So my one ask of you when you go back to your various teams is to review your standard operating procedures, your SOPs, especially around controlled drugs management, and actually add in about reporting any incidents, any concerns CD related, using that link, and put that link into your SOPs. And not only does that give us a better picture, especially from GP practices, around the themes and trends associated with controlled drugs, but should you need to, it actually helps you to demonstrate your rigor and your governance process and the transparent approach you're taking around your controlled drugs management within your practices. I'll hand back to you, Sarah.
Yeah, thank you for that. So it's really about, for the last few minutes, if you've got any questions.
Thank you for that, Sarah and Vijay. Really helpful. Sabeer's asking if you can give some examples of reporting from GP practices.
Well, I think it's a very good question. We get very little at the moment in the way of reporting, and we would really hope that by raising awareness through opportunities such as this, that we would increase the reporting from GP practices. I think the main area in which we've recently had reports, we had one from a GP practice where there'd been a patient requesting multiple sort of supplies of controlled drugs. And then there'd been, through no one's sort of bad intention, but there'd been a lack of communication within that GP practice. So we found that multiple clinicians, including non-medical prescribers from that same practice, had all sort of prescribed for this patient, which had resulted in them getting multiple supplies within a very short time period. And that actually got fed into us. We also do get fairly regular reports of opioid seeking patients. What we have to be careful of, we don't really want to get lots of patient identifiable information. So that's where the challenge comes in. It's more around sort of raising our awareness, and then we can always come back to you maybe separately if there's anything. But what we try and avoid too much. We can send alerts, but we are very hesitant to, because where that's involved, it's quite time consuming. It involves our call to guardian. And we don't really want to be signposting lots of people to sort of posters of patients, you know. I mean, that's not really what it's about. It's about trying to look at the patient in front of you, what's their clinical need, trying to keep that patient maybe managed through a named GP, maybe if there's other GP practices that then share that patient's also accessing their services, trying to get a bit more collaborative work amongst those GP practices. You can see where we're trying to go to, and also to providing an appropriate outcome for the patient, because just everyone refusing to prescribe ever again for them without the appropriate support behind it will maybe just lead to that person seeking controlled drugs elsewhere. So it is about appropriate support. Do you get
involved with patients clinically? So often these patients are, you know, so you don't. Okay. So apart from picking up,
not appropriate for us to do. No, we're there much more to look at the governance side. Obviously, we're very happy to have a conversation, but we would very much defer to the clinicians. And the only other one that I think, as I said, alluded to earlier, was we've had some issues around misselection and misprescribing for paediatric specials, controlled drugs, gabapentin, Oromorph, that type of thing, morphine. Vijay, have you got something to add?
Yeah, just to add to what you said, Sarah. So one of the reports that we've had, as Sarah said, around controlled drug seeking patients, from that, and we were able to support the surgery with their own kind of approach to supporting this patient, but also from that incident report, we were able to pick up that there was also a community pharmacy involved, and actually we've now had a professional conversation with that pharmacist and the superintendent of that pharmacy in terms of could they have raised the awareness earlier, because they had the oversight around this particular patient bringing in prescriptions from various surgeries, because there was multiple registration involved as well. And I think that's the benefit of having centralised reports coming through to us, that we do have oversight of the trends as well. We've also supported GP practices now where they're making general inquiries around where some of them do hold controlled drugs, and actually which ones they can destroy, for example, appropriately with their own records, and which ones would need authorization from the CDAO team. So I think the more we get in terms of intelligence reports and concerns being reported, I think we can then add to our armory of support and guidance we can give.
Okay, thanks. I'll put any questions in the chat bar.
There's just one more question from Sophie. First of all, Sophie says this has been very useful, thanks. What she's asking is that can controlled drug cases be discussed anonymously in the first instance to see whether a concern needs to be raised? So the example that she's given, private pain clinic injecting ketamine, and then the patient insisting on liquid oxycodone.
Absolutely. Yes, I mean, we've got our generic mailbox on there. If you emailed into us, we could just arrange a phone call to have that conversation. We are aware that there are a couple of ketamine clinics in London. So again, you know, that could be fed into that conversation. So of course, as I said, it's much more about appropriate and safe management than it is about us getting involved directly with any individual patient. So it wouldn't necessarily be that we would need the name of the patient, just be happy to have a call generally. Yeah.
Thank you. Really helpful. Any other questions, opener?
No questions, but Dr. Sen has mentioned that there's an update on the controlled drug and new risk assessment template that's in Practice Index, and that he'll share that as soon as possible.
And I assume, Sabir, it's quite important and CQC are quite interested in these kind of processes.
It's going to form part of their regulatory oversight and assurance, isn't it, that you've got an appropriate route to escalate controlled drug concerns. Yeah.
No worries. Thank you. If there's no question, is there, opener? So I think no raised hands. So thank you very much.
We haven't run too much over time either. I don't know if it's too bad. So
fine.
Lovely to see you. We'll leave now. Thank you very much.
Thank you for coming.
Everyone.
Bye.
Bye.
Bye. Paula. Hi, Paula.
Hello. Hi, everyone.
So I just hand over to you. You're going to give us a quick update on some of our services and development, and a bit of an update on 7-day access as well.
Yeah, indeed. Hi, everyone. I'm Paula Beer. I'm the Director of Patient Services at NHC. So I just wanted to take you through just a brief refresher on the services that we're currently providing, some of our planned improvements, and then also just to give you a brief update on where things stand for the borough as a whole in terms of the COVID vaccination programme. So just in terms of our services, 7-day access, you'll all be very aware of. So our current service provision is that we are commissioned to provide 203 hours of appointments per week, which equates to 810 appointments, and that's across, sorry, I've lost my slide there. Thank you, Maggie. Sorry. And those 810 appointments are across GPs, AMPs and nurse slots. So each week we are required to make 20% of our appointments available to UTC and 111 for them to be able to book into directly. And that equates to around 162 appointments. In terms of their actual usage, on average, we're actually seeing it's around 7% of the total number of appointments that they're allocated that are actually taken up by those two services. What that does mean is if those appointments aren't used by UTC or 111, they are available to primary care to book into as well. The average service utilisation, we're running at around 95% generally. And we do tend to see that utilisation is slightly higher at the Glen Road site rather than Plashet. What we have seen, and it is increasing week on week at the moment, unfortunately, is a very high DNA rate for our nurse appointments. It's averaging around 27% at the moment. Last week was 33%. We do see most frequently the DNAs are on a Monday and a Tuesday. Patients do get reminder texts of the appointments, but unfortunately that rate is quite high at the moment. However, across all of our clinician groups, GPs, ANPs and nurses, our average weekly DNAs is at around 5%. Thanks, Maggie. So this is just a little bit of a visual. The top box just shows you across Glen Road and Plashet Road for the last 4 weeks, the number of appointments that have been utilised by patients. So you can see that certainly in the early stages of January, the numbers were quite high in terms of utilisation. There's been a slight drop off, but it's pretty consistent over the last 4 weeks or so. And then the pie chart at the bottom just shows you the referral source. So understandably, the largest percentage of referrals are coming from our GP practices, and a very small proportion are coming from UTC and 111, with the majority of the bookings from those two services coming from 111 rather than the UTC. Next slide, please, Maggie. Thank you. So just in terms of some planned service improvements, you would have seen an email that came out to all practices last week, where we're currently working on a model where we're going to move to a fair share allocation of appointments per PCN. And that's to really help us address some of the equity issues that are currently in place across the borough. So we will be commencing with a pilot, and that will be with Docklands PCN starting on Monday, the 14th of February next week. And the intention is that we will roll out the fair share allocation of appointments to PCNs across the borough from the 1st of April. We're also looking at how we can increase our appointment slots in the current model, as well as the potential for a third hub, and that would be located in the south of the borough. So I've just included here a table that shows you an example of how the appointments have been allocated to Docklands PCN across the week. So based on the combined list size of the PCN and the number of total appointments available in the service across the week, for this particular PCN, it equaled 88 appointments. So this is an example as to how they've been spread out across the week. There's also just on the right there a screenshot as to how those appointments will look on EMIS for your reception staff. So the bookings are still through cross-organisational booking, but we have labelled these particular slots for the Docklands PCN, and we would ask all practices to ensure that unless you are part of that PCN, that you do not book into these slots, please. We will be doing regular monitoring, and we will be sharing data with all practices on a monthly basis, the uptake of these slots, and obviously any issues that arise as we move towards the full rollout of the fair share allocation process by the 1st of April. Next slide, please, Maggie. So the other services that we currently provide are in relation to UTC and 111. So for UTC, we have a number of services. So we provide GP cover currently on site at NUHT in the UTC department. And at the moment, that's 4 days per week, and the cover is provided between 4 p.m. and midnight. From the beginning of next week, that will be expanded, however, and we will be providing cover for 7 days a week with GPs on site. We also have the Stream Away service, which runs 10 till 10, 7 days a week, and that's delivered from Essex Lodge on a Monday to Friday, and then Glen Road on a Saturday and Sunday. And that provides 4 appointments per hour for patients that are streamed away from the UTC with a primary care disposition. And those 4 slots per hour include 2 face-to-face. And across the total of the week, we're providing roughly 336 appointments, with average utilisation of the service around 97%. We also provide a UTC and 111 bypass service, which provides on average 313 telephone and remote appointments a week, which is in addition to the Stream Away service. And again, that runs 10 a.m. till 10 p.m. 7 days a week. And the number of appointments are interchangeable between UTC and 111. We don't allocate a set number of slots per service. And the utilisation for that service is around 93%. In terms of planned service improvements, as I mentioned, we are moving to a 7-day cover at the UTC as from next week. And we will also be looking to consider a further rollout of the face-to-face appointments in the UTC Streamaway service, in particular increasing the number of face-to-face slots that are available in the evenings and at the weekend. We also provide the home monitoring service, which is in line with the National Pulse Oximetry guidance, and we provide the virtual ward service. So the home monitoring service is ongoing. That hasn't been stood down at any point during the pandemic. And this is for patients with suspected or confirmed COVID who are either over the age of 65 or those that are under 65, either in the CEV group or who have risk factors that make them at risk of severe COVID. So we did temporarily increase the provision of the service in late December through January because there was a significant increase in the number of patients being referred in. And the clinical cover per day was increased to 3 hours from the 2 hours we were providing before. And on average, we were seeing 35 patients in that service a day. However, that has now dropped off again, and we're averaging around 15 patients being actively monitored. And accordingly, we've reduced the clinical cover back down to the levels we were at before the surge. In terms of the length of stay of patients in the home monitoring service, it's generally remaining at around 10 days average across the patient groups that we're seeing. And we would encourage our GPs on the call and practices to continue to make bookings into the home monitoring service through the cross-organisational EMIS appointment slots that are available. We've also continued to provide the COVID virtual ward throughout the pandemic. And essentially, this is an intermediary service between secondary care and primary care, where patients are able to be discharged, but they may be waiting for additional test results, etc. But that doesn't prevent them from returning to their place of home. However, there's just a little bit more work that's needed with the patient before they get discharged fully back to their registered GP practice. So we provide that intermediary service. In terms of some planned service improvements, there are discussions underway at the moment about expanding the virtual ward provision to cover non-COVID activity. And currently we are in discussions around providing that in support of ambulatory care, respiratory services, and also the rapid response team. So before I go on to the vaccinations, are there any questions on any of those services that we're providing?
So Paula, there's two things. Hazel's asking, can the practice nurse appointments, will they be made available to everyone if they're not booked on the day?
Okay, so in terms of the fair share allocation, the system will be that at 3 o'clock each day, any appointments unused by the PCN will be released to all practices across the borough.
Okay. Wax, you've got your hand raised.
Have I? Thanks, Nadine. You're right.
Probably legacy from last
Paula,
time.
I just wanted to say thanks for presenting all of that. That's brilliant, amazing services. If in your COVID uptake report, if you could just mention the roving team's work as well. This week I've been receiving some brilliant documents through from NHC and the roving team, where not only have they been going in and doing the vaccination, the flu, they've been taking blood pressures, they've been doing urines, they've been referring to social prescribers. It's all coded information. I don't think any of my patients have been missed off the list. They communicate with us when they're not able to do a patient and look to make an action plan as to how we can get that done. It's absolutely brilliant way of working and a real demonstration of how a service should be run. And so if you could just give an update on what things that are roving team would be really helpful.
Thanks, Wax. Thanks, we'll do that. Just to add, so in terms of our services, sometimes there's a bit of confusion about what we're doing for practices and what we're doing outside primary care, traditional primary care. So the 7-day access is primary care resource, and we're trying to get to a place where there's equity and geographically it's fair as well. So we don't want patients travelling too much. And historically, there's been a bit of a problem. So we're hoping to move to equity across networks and practices. So there's not too much unequal distribution of appointments. And location-wise, we're looking at going to 3 locations quite soon. We've got Glen Road, Plashett, and looking at Docklands, and also maybe 4 or 5 hubs in the future to make sure we're covering all of Newham. The other services we have are UTC, Divert, and 111 Divert, which are from a separate pot. They come from the system. They're not primary care funds or resources. The aim is to make a bit of a profit and invest that back into primary care. Is that right, Karen?
Yeah, that's absolutely right.
The UTC Divert, which is patients being streamed from A&E, Glen Road and Essex Lodge are used because of the proximity, and that's one of the requirements. You can't have someone being diverted from Newham Hospital to the other side of the borough, so that's why we use Essex Lodge and Glen Road. Hope that clarifies a little bit.
Paula, before you move on, there was one question about how people can refer into the home monitoring service.
Yep, so sorry, I just did a quick reply on that one. So it's done via cross-organisational booking on EMIS into the slots that are marked HMS, which is the home monitoring service. Then our clinicians will make contact with the patient to do an assessment, and then we make arrangements to send the relevant equipment out to them, and the calls daily are then scheduled with those patients. If it helps, we can send the referral criteria and the pathway back out to practices again. Okay, so I'll just quickly go through some slides around the current vaccination programme. I'm aware that Helen's on the call. The roving team doesn't directly sit with me, so I might just hand over to Helen really briefly, just to give that update, if that's okay. So in terms of the vaccination programme, these are just some slides as part of the data pack that's produced for us on a regular basis through the NEL team. So as you can see, the performance is generally very good. The areas that we're really focusing on at the moment are particularly around the 16, 17-year-olds and also the 12 to 15-year-olds, particularly those that are in the CEV groups, alongside those that are in the healthy groups as well. We haven't as yet started generally in Newham the 5 to 11 CEV. Most sites are still going through the assurance process to be able to commence those groups. However, practices are encouraged to start running all of their searches, but also just to review the lists as well. One of the lessons that was learned quite early on from the 12 to 15 at-risk groups was that the search didn't necessarily provide the information that the practices were expecting to see. So there were either patients on the list that weren't appropriate or patients missed off. So we would encourage you to run those searches and then just to review the lists, please, to make sure that they're accurate. Next slide, please, Maggie. This is just a snapshot as to where we were on the 1st of February with regards to the booster programme. So boosters across all ages down to the 16-year-olds currently standing at 58.8%. There are, as you can see, around 16,000 booster doses that were still left to do on the 31st of January. That does exclude all of those that have been actively coded as having declined the booster jab, but we know that there is still some more work to be done at individual practice level to ensure that there is a consistent approach to coding those declined. Next slide, please, Maggie. So this is also produced weekly. It shows where Newham patients got their doses in the last 7 days. Generally, what we've been seeing is that Wood Grange is an incredibly popular site, and that's testament to the work that Wax and his team have done. Liberty Bridge, the SLG site, is also very popular, as is Essex Lodge. And generally, they are near the top. For the last 7 days prior to last week, although we did see Westfield see as an increase in activity. That was generally, though, because there were some issues with supply in the system for the LVS sites. So that would have covered SLG, Essex Lodge, Wood Grange, Star Lane, Wordsworth and Westbury. Unfortunately, we've not had the ability to do any direct orders off of the Foundry system for some time until this week. And all stock came through mutual aid, which brought its own challenges, unfortunately, in that respect. but the numbers are still very good, and it's really encouraging to still see that there are a number of first and second doses coming through. And next slide, please, Maggie. And so this is just a further breakdown. We are provided with data on a regular basis now in terms of the vaccination uptake per ethnic category. And this is just a visual display of that data as it's presented to us. I think that might be the last slide, Maggie, in which case I wonder if Helen, if you wanted to just, oh, sorry, just briefly, this is also the flu position by priority group, just by way of an update. But I wonder if Helen just wanted to come in briefly on the roving team to give that position.
Yes, thanks, Paula, and thanks everyone for supporting the roving team in the way that you have. It's made life so much easier to be able to communicate with the practices where we've come across particular issues that have needed repeat prescriptions or new prescriptions or safeguarding alerts. So it's been really helpful to be able to work as a much wider team. Just to let you know that the roving team's currently on the bus out in Plashett Park, I think at the moment, working with LBN to take the approach to hyper-local. We're doing all the rest of the things that you know us to be doing, which are the calling the various lists. We've noticed that there is we've received an updated search from the clinical effectiveness groups, which is showing the variation in uptake across a couple of the eligibility cohorts. So for those practices and PCNs where there seems to be a discrepancy, we're writing out to the practices to suggest that if it would be helpful that we can allocate an admin worker to support the call recall directly with your practice. Now that can be either remotely if you send us your list that you'd like us to call, or we can place the admin worker in the practice, which I think probably is the better option to try and reach some of these more reluctant patients at the moment. So yeah, all going well. The funding is till the end of March. We're hoping to be able to extend that, but we don't know what the news of that is yet. So anybody anywhere that requires a vaccine, just let me know.
Thanks, Helen and Paula, for that great work. But it does look like we're going to be kind of bringing down our services, and John's just mentioned that as well. Wax, you want to come in?
Helen, I don't want to lose that thread. There's more that roving team is doing, a lot more, and thank you for being so humble with that. And I think that there's more that the team can do. You know, the work it's doing along with the chronic diseases and stuff is super important, and it's a relatively big population that is housebound. So you know, we need to build on that, because actually we are in a situation in Newham where community services are in a difficult situation and have been for too long now. There's some golden nuggets there that I think that we really need to build on.
That's fine, thanks. Any questions in the chat bar, Bruna?
There was just some comments from Dr. Sen, but I think Karen's answered those. And I don't know, John, if you wanted to come in and say anything.
Hello, I was just going to say what a brilliant job Helen's done with the roving team. So thank you, Helen. And I think, you know, when we look at some of the services that Paul outlined, it's really important that we strengthen our connection between primary and secondary care around urgent care, which is something we're doing, which is really helpful as you share the burden of all of this urgent care. So we're hoping those links will be strengthened and we'll build a more resilient urgent care system, because we recognise under the recent strain that it's been under, how fragile it can be at times. And that's for children and adults. So I'm really pleased to see that work underway. And I think it's the hard yards of the vaccination programme now, isn't it? And demand is dropping. So thank you for all your continued efforts and continue to vaccinate people in Newham.
Thanks, John. Yeah, no, I agree about the urgent care part. I mean, I think we in primary care we could do so much of the UTC work quite well, including kind of minor illnesses and even minor injuries. Really, it's primary. A lot of it's primary care work, which turns up at the A&E front door. Thank you, Helen and Paula, for that. Thanks, John. Should we move on to our next item, which is a phlebotomy update? Hi, Helen.
Hi, thank you for having
Hi,
us. You've also got somewhere on the call Joe Raphael, who's the service manager for phlebotomy, and Jackie Burkett, whom I'm sure you all know, who's our phlebotomy manager and has been for many years in Newham and has probably met you all over recent times. So, yeah. I'm going to start with just a really brief sort of background, just to let you know, really. In 2019-20, we saw 369,224 individual patients across the 4 sites, which I think, as everybody knows, are Vicarage Lane, Shrewsbury, Appleby, and who have I forgotten?
Manor Park.
Manor Park, yep. And we've worked it out that the cost per contact at that time was £1.47 per patient for their blood tests. So I was expecting to see quite a dramatic drop during COVID times, but actually we've still continued to see 25,000 patients every month. So that wasn't what I was expecting to tell you, but we've carried on doing quite a lot of phlebotomy throughout the pandemic. One of the things as a background, we've been part of, and I'm sure some of you have as well, the Well-Wide Virtual Phlebotomy Transformation Group, which started prior to the pandemic, but soon was overtaken by circumstances, I would say. And some of the aims, there's quite a lot of aims for that programme, and as some of you will be part of it, you'll know, but one of the big aims was for patients to be able to have blood tests anywhere in East London and to introduce paperless solutions to phlebotomy. One of the first major sort of decisions taken by that group was the implementation of an online booking system, and SwiftQ was the booking system that was chosen. Say that was nothing, not specifically ELF related or Newham related. It was across all three of the Well boroughs at the time. I think it's 3. Was it more? I'm trying to remember back, but anyway, one of the things before in the last one was the pandemic response. It was absolutely clear at the beginning of the pandemic, and I'm not going to talk about the weight management webinar. At the start of the pandemic, we could no longer continue with massive queues outside our phlebotomy centres, which for people who are familiar with it in Newham, we get massive queue. We were getting massive queues in the buildings and down the road. So there was certainly a request to do something in terms of our infection prevention. So we were told we could no longer have this. So SwiftQ had to be implemented at double quick speed. So the current situation is we've implemented SwiftQ. We've got kiosks and televisions installed in all the sites. Hopefully you will have received your publicity, which is we have had regular mail outs from the CCG, but we've also sent round now some posters to put up, some QR codes to log on, sort of as much as we can think of to help patients move to an online booking system. We're also hoping to have an article in the Newham Recorder. It's all written, but it hasn't actually appeared yet. I think it's fair to say at the beginning of this process, we were very aware that patients in Newham are very used to and loved their old walk-in system. So we tried to maintain a number of appointments for walk-in and booking. And I think what I would say is, with hindsight, I think we've probably got the balance wrong. And we are moving to many more booked appointments. So we started off with 20% of the appointments being for booked appointments, and then we've now moved that round to it being 80% available to book, because we were quickly realizing that there were quite long waits for those booked appointments. So one of the things I would say is with SwiftQ, it does give us the ability to manage things on an almost day-to-day basis and to look at the utilization of the clinics. So we are very much trying to keep a close eye on things and alter and tweak things as we go along. One of the things we were very keen, and I know Rima's on the call, and I think she's told me every week that we need to maintain our capacity for urgent appointments. So we have tried our very best to do that, and they are available for walk-ins on the day. And the only thing I would say, and a big plea to everybody, please can you print urgent? And Joe's nodding at me, because we've had quite a few people who have tried to sneak into the system by writing urgent over their own papers. So if you print that it's urgent on the form, then we can accept that as an urgent one. Someone sort of crayon on there saying urgent really doesn't cut it. So please print it on there, and we will do our very best. What I would say is we've looked at the capacity, and I thought there would be a lot of urgent ones, and we were saying, you know, what balance would we need? But in fact, people are very responsible, as I would say, and maintaining urgent really only for urgent. I've got a bit of a definition of urgent, which was given to me by Kate Corlett, who apologises for not being here, but she's very clear that urgent bloods are where the result will make an immediate impact on your management of the patient. And as I say, please print urgent on the form. We're implementing at the moment a dedicated booking helpline. Now, what I would say at this point is it isn't an alternative to using the online system, because what we're very clear is if we gave everybody a choice, it might well be that we would have to maintain a separate switchboard just to do blood test bookings. So it really is a helpline for yourselves. We're going to get the number out to practice managers, I hope, in the next week or so, whereby if you've got somebody who really doesn't have access to help to book online, or hasn't got access to a mobile phone, or can't be helped in the surgery, then we will have a person on the end of the telephone. The other thing we've had to do as well is put security guards on site to support staff. We've had quite a high level of violence and aggression from patients to our staff, and to the point where we've actually had to employ security to do that. We've only got one at the moment, so I think that's a good sign, and he's at Shrewsbury. So fingers crossed we won't have to be doing that for too much longer. In terms of the next steps, I say the move to increase the number of available booked appointments. So there are available at all sites for Monday onwards appointments to be booked. So hopefully the balance is now better. As I say, we'll be monitoring the attendance and the booking data and reviewing the capacity of the clinic. So we are doing that as we're going along. And we will hopefully be able to analyse the actual booking data going forward. So looking at age groups, ethnic origin, times that the clinic is popular, quite a lot of information is available to us now, which we didn't have before. Now, this is the bit that you will probably be pleased to hear. We're hoping to remove the need for the printed GP form. So I believe we are almost there. Someone, I think, put a question in there, how long will that take? It's a question of printers and technical things that probably are not my forte, but we are very keen that we are able soon for you to order your blood test by pressing a button, and somehow us being magically able to print those labels off in the clinics. So that is our very next aim. So I think once we've got the balance sorted out, we'll be able to concentrate a bit more on making sure that happens and pushing that forward with our IT departments, and I think it's TQuest and EMIS as the providers. So the other thing we need to do is formalise our domiciliary phlebotomy services and the criteria. That was one of the original aims of the project. Currently, there isn't a properly commissioned domiciliary phlebotomy service in Newham, but we have actually needed to employ 2 staff to do that. So there's obviously a need for domiciliary phlebotomy in the borough, and there are, as you've already spoken about, quite a number of housebound patients in our borough and people who find it difficult to attend clinics. So that is something we really want to work on next. And also just a plea that we are going to be maintaining a risk log and monitoring of the violence and aggression. If you do know you're sending us somebody who may be difficult or may be threatening, it might be worth giving us a heads up in advance. I mean, I would welcome any ideas, because obviously people at the moment come in with a form. We don't know them until we've got their form, and there have been some quite serious incidents of threatening staff, threatening to assault staff on their way home, things like that. So it's been, I'm sure I'm not telling you anything that as GPs you're not haven't experienced yourselves, but it's certainly gone up recently. So that's probably all I wanted to say. As I say, we'll send the booking details out to the practice managers, and I've got some questions I can see. Single point of contact when things aren't working. Urgent patients shouldn't be turned away, which is what was puzzling us, who they'd been and where that had happened, because we've had capacity for those. So, I mean, probably the best way, if people have got a complaint about the service, then our normal complaints procedure should kick in, which we can send details out about. The other issues that you've identified, probably they need to come. Probably I'm going to take the middleman out now and say you probably don't need to go directly to Rima to come to me. And Rima probably be grateful for that. It's probably myself or Joe if you've got specific issues. And if you could tell us either the specific complaints and the time and the clinic or the patient details. The more detail we have, the better we can look into it. We shouldn't have the 2-week waits anymore, because that was the wrong balance of appointments versus walk-ins. So they're all appointments now, apart from urgents. So that should help with that. And as I say, there are appointments across all of next week at all sites at the moment, when Joe and I looked earlier on. Any other questions?
Helen, quick question from Hiran about the need to register online, because some of our elderly patients are struggling with that, I think is one of the asks.
Yeah, one of the things that was talked about at the very beginning of the project was that whether if they go into the GP practice and people know that that be the practice staff or the GP themselves can advise that they may struggle, it might be helpful if the GP practice could assist with that online booking before they leave the practice. I appreciate that's an ask, but that was what was initially discussed. Again, then we will give the practice manager the helpline. But as I say, the helpline really should be for people who are maybe elderly or haven't got access to technology and could, perhaps need some support in doing that. So that's what the helpline's for. It's not a routine booking line, because I say otherwise then we'll have to implement a whole telephone system. So
Dr. Patel, you've got your hand raised.
Yes, thank you very much for your service. We should be grateful to you continuing our service. My main question is this, that you should not be tolerating any abuse from our staff. And please inform all the GP concerned if you have a staff like that, so we know those staff. In NHS, we shouldn't be suffering for any abuse or verbal or threatening behavior or anything. Please do inform us.
Thank you. I might have said that wrong. It's the patient. So if you know, I was going to say, I don't think I've had any abuse from the GP staff. It's people's patients. So I don't want to make any, but if you know you're going to have someone who might have difficulty or need some support, please do tell us in advance if they're coming or you want them seen. We can try and work our ways around that. So yeah, but
it is useful for us to know any of our staff, any of our patients behaving like that. So we should be also aware of that for that behavior. So they should not behave with us as well.
Yeah, that's really helpful. Thank you. I really appreciate
Thanks
that.
for that, Dr. Patel. Wax?
Yeah, two things. So I know there's a mention of increased capacity going in. Helen, quite a few of the practices do their own phlebotomy without a contract anyway, and have done for over a couple of decades. So there's still a conversation going on around introducing that capacity in, because absolutely, like Karen said, there's a need for patients to be looked after closer to home. And we've seen that through what we've learned from the vaccination service. And then the other thing is Helen Page is here as well. I keep talking about the service that she provided, but is there scope to do some domiciliary work through that team?
Thanks for that.
To work together.
Thank you. Yep, we will always. I mean, we've got more work than we can do, so we're always happy and open to negotiations. We'd be delighted.
That's fine. Thanks for that, Helen. Anything in the chat bar, Alpana or Kevin?
There's a few. So Bapu wanting to know if the activity, is there enough capacity in the centres because of historic activity levels? And then a quick question about appointment waits. Hang on, sorry, I'm just trying to double check this. Go with that one. Is there enough?
I'll go with that one. I suspect possibly not is my gut feeling. I think it's if you actually, the maths we did to get the cost per patient, seems incredibly cheap for me based on those figures. So I wonder whether, you know, now we're actually able to analyse the work more. I think there's either room for other providers, as Wax has said, or else an expansion or some more sites. I don't know. There's work to be done, but it's good now we are actually getting the data. I think that's the main thing.
And maybe one of the ways in which we can address that would be to Wax had asked who was the TNW diagnostic lead, because presumably we ought to prime them to know they've got to push for more capacity.
Yeah, it needs a new voice into that, isn't it? So we just did an update with everything that we've just discussed, really. Super relevant.
I was going to say, I'm questions? Not aware who it's Tom Butler from Barts is.
I think, Bapu, you attend those meetings, don't you?
I used to, but nowadays, because of capacity issues, I've not been able to. And I'm not any longer the official lead in diagnosis, but I've got a personal interest, and I've been linking up with Jackie at, regularly as well. So much so that the pilot for the TQuest printing, there was quite a lot of issues with ITs and all that. So the printer sat there for nearly a year and a half, and I had to request my printer back. But that's a different issue. I'm hoping that we can iron out all that, because Homerton and City and Acme, they have TQuest directly that can be printed from the phlebotomy hubs. And there is a solution that was shared by the Homerton lead to the ELF team as well, and the TNW. So hopefully that can be implemented. Currently in Newham and Barts, all consultants can theoretically just click a button and the patient can book an appointment or SwiftQ, turn up at phlebotomy hubs across Newham and get their blood tested without the prints being sent to their home. However, that's not the case for the TQuest. The various issues, one of the main thing being staffing and the time required for ELF team to print that out for the TQuest form. The various solution has been shared with Tom Butler and the team. So I think they're working on that. But yeah, I'm even though I'm not the lead, I've got a personal interest, and I'm happy to be contacted anytime to share any sort of follow-ups on the process that we are following for the last 2 years. Thank you.
Okay, thanks for that, Bapu. Dr. Patel, CM.
It's me again. It's me, not the other Dr. Patel. Just Helen, quickly, I wanted to ask you something with regards to clarifying the booking process. So where you mentioned that the helpline is not actually to book patients' appointments, in our practice, when this system was first started, we contacted the helpline to ask what we should do for elderly patients that are not able to book in themselves. We were advised that a member of staff could use their account and add on the patient as a relative or family member and book in for them. So this is what we've been doing. Now, fortunately, we're in a position where the admin staff have the time to do that, but I don't think it's feasible for, maybe larger practices that have hundreds of patients that need to be booked in on a daily basis. So is there any way that we can work around that, or is it that we've been given the wrong information in our practice?
Good question.
I'm trying to think where to start, and I'm looking at Joe or Jackie, who may be able to answer that. In terms of initially, we did ask people to do that. I suppose Joe, do you want to say anything about the initial process of getting people to book on that way? What we'd asked originally.
Right, hold on, can I let Jackie answer that one? Jackie's here. Hello there, hi everybody. I think the majority of people are booking their own appointments, and we are advertising it as much as we can. So we've got the QR codes, we've got little cards that we've been giving out, and I think that what we just need to sort of tell everybody is that we can only make appointments, obviously, for the people that haven't got the technology, what Ellen just said. And we do need the practice managers to actually help us as well to explain that when the service users do come in. But the admin guy that we're using at the moment as for our little helpline that we've just disputed this number out this week, is literally only for people that can't do it themselves. But we've got a bit of a hotline this week, so it's been going a little bit crazy. So I think what people are doing is just giving that one number out that we've got with this one person, and he's trying to help people make as many appointments as he can. But I think we need to really tell people it is only for people that haven't got that technology to make the appointments. But what I can do is get SwiftQ to maybe send out a link to most GPs that they can log on, and if I think there is a certain link that we can use, that you can use to from SwiftQ to make an appointment. And I do appreciate that lots of practices are really busy, but if GPs could help, that'd be wonderful.
I think we probably need to discuss it outside this webinar in terms of, is that okay, Reem, in terms of going forward? Because what we don't want to do is load practices, and we need to get the comms right if we are going to make any further changes. But yeah, I think we'll have to, sorry, just due to time, really, we're just going to have to move on, Helen and Joanna. But I think, Reem, if you could take that forward in terms of any further changes, because I think that's one of the learning points, really, is in terms of making changes to practices. There needs to be, that the comms need to be right, and it's been quite difficult in the pandemic. But thank you for coming down.
Thank you. Bye.
Thank you. Bye.
Hi. Kavita, Training Hub update. Sorry, we're running a bit late again.
That's okay.
Is Sule here as well?
Over to Sule.
Hi, Sule. I'll just hand over to you.
Hi.
The update.
Okay, I am aware of the time, so I will try to do this very quickly, and I am more than happy to come back if we don't have enough time for a good discussion, because there's quite a lot that we wanted to cover. We want to give you a bit of an update on the national procurement, our ARS champion roles and approved learning environments. Maggie, if you can directly go to the fourth slide, please. Yes, thank you. So in terms of the one before, please, Maggie. So just to give you a bit of a context, I'm sharing the presentation that HCE shared at the London-wide workforce group, which is shared by NHSCI and HCE jointly. All the training hubs are part of this group, and we attend that regularly and provide updates and also receive information. We have shared these slides with our Newham Training Hub steering group in January also. And really the key is that training hubs will continue to be networks working together to enhance multi-professional training, working very closely with our local stakeholders and PCNs in our localities. Next slide, please. So in terms of the core functions for the training hubs is described in the operating guidance. Placement capacity to support the supply into general practice roles, including GPs, GPNs, physician associates, supporting workforce planning, and of course supporting multi-professional educators' capacity and integrated educational programs, as you most probably know this already. Next slide, please. In terms of the procurement then, training hubs are part of the long-term plan, people plan, ICS people functions. So the procurement exercise that the national team took really was to actually offer a level of sustainability for the training hubs, because our infrastructure funds were annually, and through the procurement, the kind of infrastructure funding will be for 3 years potentially, with an extension of the contracts to another 2 years, so in total 5 years. This exercise took place in between September and October, so that was a very short period of time for us to be able to respond in our localities, and the evaluations were carried out between October and December. And only this week we have an update from HEE indicating that the next stage of the process will be the contracts to be signed. And we were told that there are some delays with the national team, but they are actually working on this. So as you can see on this slide, training hubs will be supporting primary and community care integrated training and education, approving additional learning environments in our local areas, and supporting workforce planning and developing educational capacity. Next slide, please, Maggie. So in terms of London context, there are 5 ICS level training hubs, and it is expected that each locality will continue to deliver activities and engagement within their footprints. Next slide shows you the map across London. The Southwest London is the only area the procurement process will be repeated. They didn't actually choose a provider. And the next slide again, please, Maggie. So the interim arrangements HE will be putting in place while the procurement will be repeated in Southwest London in April. Next slide, please. So this slide shows the system governance in terms of how training hubs are actually linking in their localities with their systems, as well as their PCNs, but also in terms of the reporting and the communication lines with the HE, NHSCI, and STP and ICS. If we look at the next slide, please, Maggie. So this is our initial draft that we are going to be discussing with our host as well as with the training hubs in terms of looking at how we are going to be organizing ourselves in terms of our accountability and governance. So we will have in between now and April, before this has been operationalized, we are having conversations with ICP, ICS colleagues and other stakeholders, and as I said, also within our own local steering groups. So the idea is that through the governance and accountability, we will make sure and ensure the financial and organizational accountability of each hub and its leadership is in line with the HEE stipulations. We are proposing to continue having our steering group locally for local accountability, but also for support and steer of the local strategic priorities. It is really important to not link with the local ICPs and PCNs and ongoing two-way communication here. Now, Training Hub will be reporting to the host organization for operational and financial oversight. And also, of course, will report to NAL ICS Training Hub Board, which will have partners from HEE, NHSCI, ICS, Primary Care and Workforce Group, ICPs, as well as training hubs and the host organization. And then HEE will continue to monitor all training hub activities and their KPIs through the HEE Primary Care School and the regular meeting that we have with the HEE, we have been told are going to be continuing. Next slide, please, Maggie. So there's a bit more of a detail in terms of some of the roles and responsibilities for the host delivery partners and NAL Training Hub. So the host organization will be holding the contract with HEE and in turn work with the delivery organizations in each locality and across NAL, receiving quarterly reports, ensuring the delivery is on track, holding the contracts for the programs, other than the infrastructure funding, of course, and ensuring financial governance is in place. Delivery partners will ensure the capacity is in place to deliver all aspects of the HEE contracts and the service specifications in our localities. We have to make sure that we are meeting our KPIs. We will report to our host ICS board and HEE, and of course we will make sure the local engagement with primary care and wider health and social care system partners are continuing, and our priorities are aligned with the ICP priorities. Now, Training Hub will lead on the engagement at the ICS level and with strategic regional and national stakeholders and linking and reporting to primary care school, of course, ensuring reporting and monitoring of all our activities. So the next couple of slides will give you the information about the KPIs. If we move on to the next slide, please, Maggie, thank you. Very quickly, these are from the procurement document. As we are waiting to receive the contracts, there may be some changes, we are not quite sure, but we are not really expecting any drastic changes to these. So as you can see, supporting workforce planning. So what that means is looking at supply as well as demand, looking at recruitment and retention, career development pathways, including opportunities in relation to apprenticeships is looked at in our localities. Of course, clear links with the ICS people function as described here, growing the workforce, leading the workforce transformation and coordinating coordinated workforce planning. Next slide, please, Maggie. Multi-professional education programs, I'm sure this is no surprise to you, including the CPD offers that we have, again addressing the need for development of the multi-professional workforce and supporting the leadership at all levels and transformation of services. Next slide, please. Supporting equality, diversity and inclusion for the workforce, and really very strong linking in with population health needs and health inequalities, ensuring training and development opportunities are addressing these in our localities, again linking with ICS functions, supporting inclusion and belonging for all, ensuring better experience for all our staff, driving and supporting broader social and economic progress. Next slide, please. One of the functionalities that is previously held between the center in the HEE, moving across into the training hubs, which is about increasing learning environments to support to increase multi-professional placements for students so that they choose primary care as their first destination to work when they completed their training. This also formed part of our recruitment strategy, ensuring strong links with the supply of the workforce in our practices and PCNs. We will be therefore supporting our PCNs that would like to become learning environments, as the direction from HEE is to pool funding to the PCN, expanding clinical placement capacity, hopefully attracting more student nurses and potential for staff, expanding clinical supervision skills of nurse physios, etc. So the development of the multi-professional educator groups is going to be really, really important. And this process will support only one application and coordinating and consolidation of policies and standards across PCNs. Just quickly, we are going to be organizing a session with HE colleagues to discuss in particular the increasing learning environments for our PCNs. There will be an opportunity for all the PCN and practices to ask any questions that you wanted to ask in relation to that process. Next slide, please, Maggie. So this again links to the previous slide, increasing capacity and capability of the educators, linked to the suitable learning environments. If you move on to the next one, this is the last KPI slide, and that is supporting the primary care to embed new roles, growing the workforce, supporting new ways of working in primary care, and as you know, is the additional roles in reimbursement scheme and supporting those. Just very quickly, if you move on to the next slide, just a couple of updates in terms of our ARS champion roles. We have now recruited clinical pharmacist ambassadors. Ansa is in fact on this call. Ansa, do you want to say very quickly hello?
Hi everyone. I've just been asked by Kavita to come and introduce myself. Me and my two colleagues, who hopefully will be introducing themselves in the coming weeks, have come on board with the Newham Training Hub. And we're here to start to look at ways in which we can actively engage with clinical pharmacists across all of the general practices within Newham. and we hope to provide support and see ways which we can develop opportunities for them to help them with their ongoing development and training needs within the practices, and as a result be able to support the practices as well within Newham. So I look forward to working with all of you lot and probably seeing you lot all in the near future.
Thank you, Ansa. As well as Ansa, we got Abdul and Poonam in the team as well, and they all working together. And apart from our clinical pharmacists, we have the physician associate ambassadors. 2 colleagues started in last month, and they have started working with our practices, supporting physician associates, not only in terms of their CPD, but also in terms of their preceptorship. If you have any questions in terms of your PAs and including how to recruit and where to actually link up with in terms of universities as well as placements, please do let us know. Next slide, please. So in terms of other roles, we have been successful in securing funding from HE for a fellowship post for the personalized care. So the fellow will be working closely with our PCNs, supporting development of NAL induction program, develop and support the peer support models and ongoing CPD activities, and working closely with Helen in terms of looking at Newham personalization ambassador. Just on that, if I can very quickly, Maggie, share the website that we have developed so that people are aware of it. This is newly done. We actually only put this on yesterday, so we have a page where you can actually find information around ARRS, and if you look at it, you can see all different roles. And if you were to actually click on any of these boxes, you can get a lot of information in relation to these roles, as well as job descriptions, ways in which that you can actually link them in with different services, etc. So we are hoping that that will be a helpful tool, and we will develop it with your feedback. So please do let us know whether you are finding it useful, whether putting something else onto the website you might find useful, etc. Karen, I can share the link with you after this meeting so that we can send it around as well. So I think I am on my last slide, isn't it, Maggie? And that's the multi-professional approved learning environments. As I mentioned, this is one of our KPIs with the HE. You can see the current training practices here. We have worked in the last couple of months with Pelham Street Surgery, and we actually got them signed off now. Thank you, Subir. Subir is very much involved in this work, working with the training hub, supporting the practices and supporting us. And potentially we are looking at Stratford maybe becoming the very first PCN as the learning environment in coming months. That's all my slides. Apologies for running over. Thank you.
No, thanks, Philly. Sorry, we ran over actually. Any questions on the chat bar?
So there's just a comment from Tammy. Oh, sorry.
You go on, Oprah.
Tammy, I don't know if you want to share what you've written here.
Hi everyone. No, just to say that from a diabetes point of view, there are a couple of streams that I wanted to update next time. So just if I could be put on the agenda, but as Ansa was there and our additional clinical pharmacy capacity to support practices in increasing referrals, I just thought I would highlight it now. And just a gentle reminder that any of the newly diagnosed type 2 diabetics, please consider it as the remission pathway if their weight is an issue, and have those conversations. And if anyone's not sure, just email me and obviously I'll update next time. Thanks.
And I can see Lyra is in the meeting as well. Hi, Lyra. Did you wanted to say anything about the approval process? And congratulations.
Thank you, everyone.
thank you all for your support, Shule, Kavita, and Dr. Sen as well that I can see. Also Dr. Bhatti has helped a lot, and Dr. David Price. So it was there is some paperwork to do, but the best thing is that you are supported throughout the process. I had a couple of meetings with the team before I had the approval as well, which helped me focus looking at how I support the trainee, myself, the practice. So it was a supportive process, even though initially it's a lot different from what it was before, and I thought it was very productive. So we were not left on our own to fill the form. They guided us, and they also made us reflect on how we can improve ourselves and support the training. Whichever trainee comes to the practice, how we can support them and ourselves and the team. The trainee was just there actually, so he started as well. So thank you everyone, and he's just left for lunch. He was hungry, which is allowed. So I will keep you all posted how I go, and thank you. Actually, it was a really helpful discussion whenever I've had it with the training hub and all the members of the hub. So thank you.
Thank you for that. Sabir, anything you want to add? Last word?
The only last word I wanted to say, I wanted to really manipulate this word called place-based tariff. In Stratford, we got four practices are called TARS, Targeted Enhanced Recruitment Scheme, where the trainees are put a golden handshake to work in Newham. I really wanted to have more better tariff from whole over the Newham. So whole Newham should be part of the TARS, and the next communication we should have regarding to make how can we widespread encourage people to work other areas of Newham, giving some kind of incentive as already in place.
So it's only in Stratford, you said, Sabir?
Yeah, at the moment, we are getting it, Star Lane, Freemason Road, and one of the Fast for Health practices. So we have 4. Kavita, is it 4? How many TARS?
Sorry, Sabir, what was the question? I was busy typing.
Yeah, I mean, Sabir, we need some equity about any kind of golden handshakes, don't we, across Newham?
Oh, the TARS, 6. Yeah. We've got 6 TARS at the moment.
Okay.
Yeah. I don't know.
What are they? Golden handshakes for training practices, or what exactly are they?
You're talking about the TARS, Sabir, are you? Yeah, so they get about 20k over 3 years to come to an underdoctored area. So they've been chosen for Newham. How they were allocated to actual practices, I think it was just based on the capacity, really. So that's why we're so keen to get more practices to become training practices. If you actually look, I know it's so much information overload, but the last slide that Sule showed, you said that some PCNs actually don't have any training practices at all. And I think that's what we really want to start focusing on, so that we do have, and we've got GP expansion coming up as well. So I think that would be really helpful.
Okay. All right, thank you very much. I can't see any raised hands. Any questions? Yep, I agree with you, Sabir. I'd like to look a bit more into this TARS stuff to see how we can kind of spread it across Newham. That'd be great. Thank you very much. Thanks for that, Sule and Kavita. And thank you everyone for attending. See you lot next month.
Thank you.
Bye.
Thank you. Bye.
Bye.